We're sharing this occasion in part with the Lancet Commission. London and Boston have already had their Lancet Commission on Global Surgery launches, and we were thrilled when Gavin Yamey suggested that we host a launch here in San Francisco in conjunction with our center launch and celebration of global surgery. Gavin Yamey is a professor of epidemiology and biostatistics and lead in the Evidence to Policy Initiative. He is one of the preeminent global health policy researchers today and is a commissioner on the Lancet Commission on Global Surgery and the lead on the section of economics and financing. So it's a pleasure to introduce to you Dr. Yamey.
Thanks for that completely over-the-top introduction. I'm blushing. I'm red hot blushing. It's a privilege to follow three of my global health heroes. It was certainly a privilege to be part of the Commission on Global Surgery. I am clearly not a surgeon, though I was trained as a physician in the British National Health System, and in your internship year you have to do 6 months of surgery, so I did a ton of assisting. I was quite good because I was tall. I could just stand that for hours on end. And then when I was a neurology resident, one night I was on call and the neurosurgical attending was short-staffed and asked me if I would assist in brain surgery, and I was convinced that this was going to be the most beautiful procedure, very delicate, seeing this amazing organ, the brain. And, I'm still traumatized from all the sawing and the sucking. Subdural hematoma evacuation is not delicate. So, I was asked to spend about 10 minutes summarizing some of the key messages of the Lancet Commission on Global Surgery. It's a big report. I think it's available to you, 33 pages. I can't, go over all of it, but I hope to pull out some of the really important, actionable take-home messages. I wanted to just quickly set the scene a little bit. Our role really in the Commission, we felt, was to try and do something to raise the profile of these horrendous inequities in surgical care that Jaime talked so eloquently about. It's actually an issue that's been around for a while. In fact, we can go back to 1980. Dr. Houghton Mahler, Danish TB expert, he was the Director General of the WHO, responsible largely for the famous Alma Ata 1978 Declaration on Health for All 2000, by the year 2000. In 1980, he, in Mexico City, spoke to the International College of Surgeons, 29th of June 1980. His talk was actually called Surgery for All. And he said, the vast majority of the world population has no access whatsoever to skilled surgical care. Little is being done to find a solution. I beg of you to give serious consideration to this most serious manifestation of social inequity. 1980, folks were talking about this. Fast forward 34 years, Dr. Jim Kim presented at the inaugural meeting of the Lancet Commission on Global Surgery by video. And here he is. I urge you to challenge this injustice, build a shared vision and strategy for global equity in essential surgical care. You can make the case that surgery, as Atul Gawande has said, is an indivisible, indispensable part of healthcare. So superficially you might say, wow, 34 years, not much has happened, lots of inequities, but as we've already heard today, hell of a lot has been happening in the last few decades. And that's John Meara on the left, Sarah Greenberg on the right, one of the chairs of the commission and one of the commissioners, both at Harvard. And they wrote a piece in the Lancet Global Health journal called Global Surgery as an Equal Partner in Health, that really talked about the fertile ground that the Lancet Commission found itself upon. By the way, that title, no longer the neglected stepchild, you may know about a famous commentary that Paul Farmer and Jim Kim wrote, in which they called surgery the neglected stepchild of global health. To which anaesthetists often say, yeah, I think anaesthesia is like the invisible friend of the neglected stepchild. Kim's words landed on fertile ground prepared by the hard work and dedication of many individuals and groups. There was, for example, the Bellagio Essential Surgery Group, a group of surgeons, anaesthetists and others, really raising the profile of this issue. We've heard about DCP2 and DCP3 in particular. There it is, Chapter 7, led by Haile Debas, really put global surgery on the map. Haile Debas, the spiritual godfather of the global surgery movement, not in like a mafia way, but in a sort of godfatherly way. And of course the WHO's work on essential and emergency surgery. Fertile ground, thousands of providers at ground level in low and middle income countries, providing services under very difficult conditions as well. It was an opportune moment for this commission. We are undergoing a transition from the Millennium Development Goals era, which was largely focused on individual diseases, so-called vertical programs, particularly HIV, TB, malaria, not so much attention to systems building, surgical services, universal health coverage. We are now transitioning to the Sustainable Development Goals era, SDGs post-2015 era. The Sustainable Development Goals will be adopted in September by UN member states. The wording is basically done, it's up online, it's not going to change much. Universal health coverage by 2030 is there, pretty loud, pretty clear, front and centre. There is an opportunity with this UHC language, and also I think post-Ebola, the realisation of the importance of systems for surgery to rise up the agenda. Here's our commission, 25 of us, from all walks of life, from many parts of the world. I see up there a Mongolian anaesthetist, I see a Haitian surgeon, I see Paul Farmer, I see a guy wearing a pink shirt, characteristically, with a vision of providing universal access to safe, affordable surgical and anaesthesia care when needed. That is the vision of the Commission. We got together 4 times, kick-off at Boston. Second meeting was in Sierra Leone, in the midst of the Ebola crisis. Third meeting in Dubai, and a 4th meeting in Bellagio, Italy, next to George Clooney's house on the lake. Sadly, I actually couldn't get on that. There were a bunch of regional meetings as well, really important for regional collaborations and buy-in. And, you know, I've been very lucky to be involved in 2 commissions, the Commission on Investing in Health and this Surgery Commission. And they each had, I think, their own incredible kind of strengths and characteristics. The surgery one was incredibly consultative, with contributions from 110 countries. Individual meetings, national meetings, and online consultation forums. Really more of a movement, I think, than a commission. Of course, there are definitional issues. And in the Lancet, the chairs and a number of commissioners try to sort of lay out what we really mean by global surgery. Defined as a field that's about health and health equity for all those affected by surgical conditions, with a particular focus on the underserved. Although, of course, there are underserved populations in all countries. While our focus in this paper was on low and middle income countries, there was a clear recognition of underserved populations everywhere, as well as populations who are in crisis that have particularly acute needs. We did not feel that that was the comparative advantage of this commission. So in fact, if you look at our sort of scope, it really was a focus on underserved populations in low and middle income countries, while recognizing clearly there are needs elsewhere. Those needs are served in a somewhat different way in, for example, complex humanitarian emergency situations. Over the course of a quite busy, quite productive 2 years, we published the report, Global Surgery 2030, just came out. Along with the report, I think, again, a really fascinating aspect of this commission has been the production of almost 20 teaching cases. 6 completed, another whole bunch coming. They're all online at Global Surgery Info. Here's just one example, measuring surgical outcomes in Mozambique, in conjunction with Babson College, funded by the National Cancer Institute, the Rockefeller Foundation, Harvard University. And actually the day following the Harvard launch was a whole day of teaching cases. Really spectacular spectacularly valuable educational tools. There were so many gaps in the research literature that we also embarked on a fairly serious research effort. Full papers published across 5 journals now, and the research abstracts, 57 research abstracts published in the Lancet. Here is one paper that I was lucky to be involved with, led by Stefan Vergey, now at Harvard, on the costs and timing of scale-up. And then we hope, obviously, that this is now going to be carried forward by the advocacy community, particularly the G4 Alliance. The report lays out the state of the field. What is the status of surgery right now? It also looks to the future. If we could scale up surgical services, what would the health impacts be? What would the economic impacts be? And it lays out a set of policy recommendations both at the national level and for international collective action to achieve that vision, together with a set of targets and suggested indicators. There are 5 key messages that I'm going to spend just a minute on each. Along with those recommendations and indicators, the research I've already mentioned, and you'll see in the paper in Table 7 the beginnings of a national surgical plan for each country to take and adapt. We have 4 work groups: healthcare delivery and management, workforce training and education, information and management, and finance and economics, which I chaired with Winnie Yip from the University of Oxford, Losung Conte at Imperial, and Anna Dare at Toronto. The first message that Jaime already mentioned: 70% of the world does not have access to safe surgery when needed. Now, a few years back in the Lancet, a paper by Tom Weiser and his colleagues, including Atul Gawande, suggested that was around 2 billion. How did we get to 5 billion? The 2 billion figure used only one particular indicator of access. The 5 billion figure comes from a larger set of indicators of access: timeliness, surgical capacity, safety, and affordability. And using those criteria, it was a lot more than 2 billion. We also set a target, one of our several targets you'll see in the report, that 80% of people should be covered by 2030. This is feasible, as we showed in our scale-up modelling. The second message, and I would be delighted to talk through the modelling with you in the Q&A if you'd like to find out about the model and if I can describe it, is that we need to be doing 143 million more surgical procedures to be truly offering equitable, safe, affordable surgical access. Not surprisingly, most of those will need to be in low and middle income countries. Right now, the poorest third of the population are receiving only about 6% of the needed procedures. Of course, that is going to require fairly serious systems building. We have a shortage of staff, of space, and of stuff, as it's become known. On the staff front, the data suggests that you really need at least 40 surgeons, anaesthetists, and obstetricians per 100,000 of the population. That's really a minimum. And in fact, 44% of the population has fewer than 20. So we have a long way to go on the workforce. We also know that we need stuff. There are physical infrastructure weaknesses, and we need space. What we try to do in the Commission in coming up with the capacity that countries have right now to carry out surgery is to look at what we called bellwether procedures. We defined 3 bellwether procedures. These are procedures for acute conditions that really all first-level hospitals should be able to provide. That is emergency obstetrics, a laparotomy, and the management of an open fracture. And if you can do those, obviously there are many others that you can do. It was a way for us to get a handle on what coverage was like right now, and of those, perhaps not surprisingly, the highest coverage is for caesarean, the lowest for treating open fractures. Our third of 5 messages is that every year 33 million people are facing catastrophic expenditures. That is, spending over 10% of all their income, or over 40% once food and other needs have been taken care of. That surprised us. There is a very famous study in the catastrophic expenditures world, Zhu and colleagues, they found that 150 million people experience catastrophic expenditures, of whom we suggest 33 million, that's from surgery. And that's because surgery is almost always, in low and middle income countries, paid for out of pocket. Out of pocket expenses are impoverishing. For surgery, the conditions are life or limb threatening, they are unpredictable, you're not going to be saving a head for them. And if you were to add the costs of transport and food, that actually brings you up to 81 million people. Hugely under-recognised aspect of global surgery. The fourth is that investing in surgery, we can do it, we can afford it. It would have enormous health and we suggest economic impacts. Now look, I personally, as someone trained in the NHS, perhaps not surprisingly, I'm very comfortable with the notion that we should be practicing medicine, improving public health, for reasons based on morality and ethics, social justice and equity. Fine. The reality is, however, that many decision makers, particularly at the ministry level, are more persuaded by economic arguments. The good news is, I think the economic case is very strong. The conditions have a large macroeconomic impact, the treatments are very cost effective, and as I said, the costs themselves are mostly out of pocket and are pauperizing. And yet, the way in which we finance surgery right now is completely abysmal. We actually have no idea at all, none whatsoever, on how much the world is spending on surgery today. Impossible to know. Aid for health, there is no tracking of how much is for surgery, and national health accounts don't track surgery either. Together with colleagues up at IHME, Joe Dealman, we looked at 958 national health accounts from the last 20 years. Only 2 countries, Georgia and Kyrgyzstan, track how much they spend on surgery. So there is no way on earth we can know how to close the surgery gap, because we don't know what we're spending right now. The financing systems are creating barriers and impoverishment because they're mostly out of pocket. And the way in which we pay providers right now is not promoting quality and efficiency. Jaime mentioned the $12.3 trillion figure. That is the value of lost output if we do nothing. If we do nothing and we don't scale up surgery, over the next 15 years in low and middle income countries, there will be $12.3 trillion in lost output. It's quite hard to get your head around, and so another way of looking at it is this. Take a look at the blue line. That is the percentage GDP loss that will happen if we don't scale up surgery. It's almost 2% in low and middle income countries by 2030. Now, in the malaria world, when Jeff Sachs and John Gallup published their paper showing that malaria knocked 1.3% of a country's GDP, that was completely game-changing. All of a sudden, people sort of opened their eyes and went, oh my God, this disease is knocking 1.3% of our GDP. It was a game changer. It was one of the reasons why there was a rise in financing for malaria. Surgery is doing even more than that. We hope these figures are going to lead to the same kind of awareness and policy action. We also know, as Tiffany Chow and colleagues have shown, that surgical treatments are best buys in global health. As cost-effective, equally as cost-effective as many of the conventional tools that we consider to be best buys, like vaccines, antiretrovirals, and bed nets. Yes, it's a lot of money, $350 billion, to scale up surgery to an adequate level, but that's only $23 billion a year, which is less than, much less than 1% of the additional GDP that will become available to low and middle income countries by 2030. Most of this could be funded domestically if countries increase their domestic financing as they grow. And as Jaime already mentioned, the losses, the $12.3 losses, are much, much larger. And finally, surgery is an absolutely indivisible, integral part of healthcare, of health systems, and of universal health coverage. Whether you take a life course approach, surgery is needed at all stages of life. Whether you look at different diseases, surgery is needed for almost all diseases. And whether you take a place of delivery approach, there's a role for surgery everywhere, from prevention to primary care, secondary and tertiary. We're going to need it for UHC, for the SDGs, for poverty alleviation, and for many other areas of health improvement. Much more information at globalsurgery.info, and I'll leave you just with a reminder of our vision of universal access to safe, affordable surgical anesthesia care when needed. Thanks very much.